Mona Forrest, and on behalf of the Canadian Cancer Survivor Network, I'd like to welcome you to today's webinar titled The Cancer Medication Geographical Roulette in Canada. The presentation today will focus on disparities in provincial reimbursement for cancer medications and what patients can do about it. We will examine the different ways that cancer treatments are managed and funded across Canada and outline the impact this has on patients depending on where we live in the country. We'll be joined by Jerry Jeffcott, who's Senior Associate at 360 Public Affairs, and Susan Turner, President of Turner & Associates Incorporated. For those of you who haven't attended an earlier webinar, this webinar is hosted by the Canadian Cancer Survivor Network. At CCSN, we work with patients, survivors, families, partner groups, and sponsors on collaborative action to identify and remove barriers to optimal patient care, to ensure access to education and action opportunities and survivor involvement in healthcare decision-making, and to support evidence-based research on ways to promote equal access to early diagnosis, timely treatment, and follow-up care. And that would be early access to medications as well. If you'd like to learn more about us, CCSN, you can visit us on our website, which is www.survivornet.ca. And right now on our front page, you can read about Giving Tuesday, which is coming up shortly. December 1st is coming Tuesday. You can also find our question and answers with the parties and candidates in Newfoundland and Labrador as they near the end of their provincial election campaign. And finally, we'd like to thank our 2015 webinar series funders, Novartis, Merck, and especially Boehringer Ingelheim for making today's webinar possible. Now we'll send it over to Jerry.
Hello, how is everybody today? Glad to have you on our call. I'd like to maybe ask Matt if you could move the slide ahead. That would be great. Okay, so as Mona indicated, we're going to cover a few areas of interest with regard to cancer care treatments in Canada today. And I am very pleased to be joined today by our guest presenter, Susan Turner from Turner & Associates. But before we get to Susan and have her comment on some of the things that, that she'll be talking about, I'm going to do a quick review or overview of the Canadian cancer care system in Canada and help you understand how cancer treatments are covered in Canada, province to province. We'll also do a quick run through of the Canadian Cancer Medication Funding Review and Approval process in Canada, and then I'll pass it over to Susan, and she'll talk a little bit about the impact of what I'll be presenting on you on patients. So throughout the process, I would encourage you to type your questions into the question box in your GoToWebinar control panel. I will review those questions and be prepared at the end of the presentations to address them with Susan as appropriate. And yeah, I just encourage you throughout the discussion to be drafting any questions, and we'll deal with them when we get to the end of our presentation. At that point, we'll conclude for the day and move along to other things. So Matt, could you pass? Yeah, great. Welcome to Susan. Susan and I have known each other for several years now. She's a terrific supporter of advocacy in cancer care in Canada. She's the president of Turner & Associates, which is an independent consulting firm. She's been doing that for about 10 years. And in that context, she's worked with the Canadian Cancer Society, the Canadian Cancer Action Network, the Campaign to Control Cancer, and in all of those cases, she's been involved in preparing reports and facilitating conferences and working groups to help move the needle on cancer medication access in Canada. So welcome again to Susan. As I said, I'm going to start by taking a little bit of a review here of how cancer is managed in the Canadian healthcare system. There are essentially four models in Canada that we can sort of summarize the there's a comprehensive model that is offered in the western provinces, British Columbia, Alberta, and Saskatchewan, where all cancer care is essentially centralized in the under the administration of a cancer agency. We have another model that where cancer agencies are involved, but where they share responsibility for treatment coverage, and that's the model in Manitoba and Ontario. In Newfoundland and PEI, the care is centralized, so you go to provincial facilities where you get your cancer care, but the treatment coverage is limited to what's provided or dispensed in hospitals, and the responsibility is shared with the provincial drug plan for those things that are not covered in the institution. And in Quebec, New Brunswick, and Nova Scotia, the care is managed at the hospital level or regional level, and again, there's shared responsibility for coverage. So just a couple of examples that I can share with you. Let's just look at Newfoundland and Labrador for a minute. In that province, all the cancer treatments are provided in the hospital setting within the province. Those are all handled by Eastern Health Authority's Cancer Care Program. And generally speaking, any required institutional care is provided within Eastern Health facilities. Excuse me. But on occasion, those services can be provided in other locations and billed back to Eastern Health. Medications dispensed in the community are subject to rules set out by the Newfoundland and Labrador Prescription Drug Program. And as I said, it's very similar in PEI. An example of the hospital-based model is Quebec, where treatment decisions are responsibility of the physician, and coverage is limited to medications that are listed on the provincial formulary, whether they're provided in the hospital or in the community. Although medications dispensed in the community are funded out of the public drug plan, while the medications dispensed in hospital are funded from the hospital budget in which you're being cared for. The Ontario model, there is a provincial cancer agency in Ontario, and it administers care provincially, so all the regional cancer centers are managed through the cancer agency, but funding for treatments is shared. So in Ontario, older, inexpensive treatments that are dispensed in institutions are covered by the individual hospital budget. But a whole list of newer medications that are dispensed in hospitals are now funded directly through the cancer agency. And like in the Atlantic, all of the medications dispensed in the community are covered under the provincial drug program. And then finally, the model out west. Well, there are some slight differentiations depending on which province you're in. Generally speaking, in this model, all aspects of your cancer care are the responsibility of the cancer agency, and that means that anything that is provided within their management responsibilities in any institution in the province, as long as they're following the provincial treatment protocols, all the medications and other treatments are covered by the government without any additional charges. So as you can see, Matt, if you can go to the next slide, as you can see the there's quite a disparity. Sorry, can you go back just to the slide with the map? Thanks. So the what I was meant to mention here is you can see in the context of this this graphic that both in terms of how the treatment is funded and how the review of those treatments are undertaken is very disparate across the country, and lots of different combinations as to how that gets managed province to province, which explains what the title of this this webinar is for today, which is the geographic roulette in Canada. And you'll see from this that depending on where you live, very different ways of managing your care. Next slide, please, Matt. So, talking a little bit about treatments now, I can give you a bit of an overview as to how those products, those treatments are reviewed and approved in Canada. Essentially from the drug development process, which takes place within, well, globally, basically. Some of it is done in pharmaceutical industry facilities, some of it is done in academic facilities, but all of it results in a variety of new innovative treatments being offered for sale. In Canada, those products need to go through a detailed Health Canada review process that takes approximately 1 year for the department to look at it. And if you're successful in proving that the medication does what you say it does, and that the safety profile is okay, then you get something called a notice of compliance, and you're therefore able to legally sell the medication in this country. At that point, there's a pricing review process that takes place at the federal level through the Patented Medicine Prices Review Board, which establishes the ceiling price at which the medication can be sold in any market, whether that's private or public, across Canada. However, even after getting your NOC and your price from Patented Medicine Price Review Board, you still have to go through additional processes. Now, you can, in fact, the manufacturer can, in fact, sell the medication with the NOC, but in most cases, you need to go through another couple of steps in order to get widespread funding. So one of those is through the Health Technology Assessment process. In most of Canada, that's conducted through the Canadian Agency for Drugs and Technologies in Health. For cancer medications, the program is called the Pan-Canadian Oncology Drug Review. For non-cancer medications, the Common Drug Review. In Quebec, they have their own health technology assessment process called INES, and essentially all of them do similar, though not exactly the same kinds of reviews, to assess the comparative cost effectiveness of new medication. And essentially what they're doing in that context is comparing the value proposition of the new medication against what's already available for a given treatment, a given disease or condition. The health technology assessments are outside of government. They provide a service to government. They produce a recommendation, listing or reimbursement recommendation with a lot of information about the value of the medication, the impact on patients, and how it may compare to other treatments. Those recommendations, which essentially suggest whether a medication should or should not be funded, or if funded, under what clinical circumstances they should be funded, those recommendations go to the provincial drug programs. And the provincial drug programs have their own process. There is, before they make a decision, it goes through the Pan-Canadian Pharmaceutical Alliance, which is a joint negotiating forum for all of the provincial drug plans across Canada. At that table, the drug plans collectively determine whether or not the recommendation should be subject to further negotiations before being added to a provincial formulary. I'm going to tell you a little bit more about the PCPA in a minute, but essentially there's a, if the plans decide that they like the value that's being offered and they can come to an agreement on pricing and budget impact, then they will make a recommendation that it be listed on the formulary. So as I said, the Health Canada review takes about a year. It takes about another year to go through those additional, a year or more, I should say, to go through those additional processes before you get to the point of patient access. So just one quick note before I start talking a little bit about the PCPA process. I've been following the chart down to the bottom here. I just want to go back to the health technology assessment box and let you know that while CADIF and INES are programs that provide services to provincial drug programs, there are health technology assessment processes that are undertaken by hospitals in the context of their decision making around which medications to fund, as well as a variety of processes that are undertaken by private drug plans. And while they don't use the CADIF or INES services directly, they produce similar recommendations which are then used to influence whether or not the medications are funded or added to formularies in private drug plans and in hospitals. Next slide, please. So I was explaining to you the Pan-Canadian Pharmaceutical Alliance process in Canada. I'm actually speaking about the process for innovative medications or new chemical entities. There is a separate process for generic companies through the PCPA, but we're not going to deal with that here. I want to talk to you about what happens with new innovative meds. So in this scenario, as I've already indicated to you, the manufacturer submits to CADIS and INES. For cancer medications, as I said, it goes through the P-coder process, and for non-cancer medications like supportive care products, that goes to the Common Drug Review. They do their review, and then depending on, well, sorry, not depending, all of those recommendations that come out of those processes, either through P-coder, CDR, or INES, then go to the provinces, and the provinces go now through a process where they actually make a determination as to whether or not they want to negotiate access to the formularies. They do that in a collective way, and all of the plans get to determine whether or not they want to participate in any negotiation. In some cases, they determine that they prefer not to negotiate, and in that case, access to the medication is not available in any of the participating drug plans. There are other cases where, for a variety of reasons, I'm not going to get into the detail at this point because it just starts to get a little bit complex, but there are some cases where they decide that they're not going to negotiate as a collective at a national level, but they're going to defer it to the participating plans to make a decision on their own whether or not they want to proceed to a negotiation with the manufacturer. But in most cases, I would say about 2/3, maybe 3/4, the negotiation occurs at the collective national level, and a decision is negotiated through the work of one of the jurisdictions negotiating on the behalf of the collective group and coming forward with a what's called a letter of intent, an LOI. The letter of intent outlines what the terms of listing are going to be, and then each individual jurisdiction participating signs a deal with the affected manufacturer, and in each case, the province has their own process in terms of how they proceed to a formulary listing. So as you can see, this is a fairly detailed process that looks throughout the two-year process, you're looking at safety, you're looking at efficacy, you're looking at price. There's a health technology assessment that looks at comparative cost effectiveness, and then there's the sort of very practical back and forth negotiation about what's involved in getting the medication into the public reimbursement framework through the provincial drug plans. So you can see that it's a relatively complex and somewhat time-consuming process that leads us to the point where you either get on or do not get on the list in Canada. And as you saw from the previous slides that I was dealing with, lots of differences in terms of what ends up in a given province or not. So Susan, maybe I'll pass it to you and let you continue to talk now about what the impact is on patients.
Hello, can everybody hear me?
Sounds good to me.
Okay, thank you very much. Thank you, Jerry, for that excellent and detailed overview of how the system works. I'm now going to turn our attention to what are the impacts on patients and what you can do about it as patient advocacy groups. So Matt, if I can have the next slide, thank you. I thought I'd start off with some comments about how well Canada is doing. When we look at the Canadian context, we tend to think about, how one province is doing versus the other. But I think it's also really important to have a look at how Canada as a nation stacks up against its peer nations around the world. And I wanted to draw your attention to a couple of reports that have come out over the past 5 years. The first one was a report from the UK in 2010 that compared developed countries, 14 developed countries, in terms of their utilization of drugs. When you look specifically at the cancer drug category, Canada ranks 13 out of 14, which is not a great place to be. We were better only than New Zealand in terms of our utilization of cancer drugs. Another report that came out more recently by Wyatt Health Management, who are on the line today, that was done for RxND, Canada ranked 21st of the 32 countries in the Organization for Economic Development and Cooperation in terms of access to cancer medications. So these numbers are not great, especially when you look at where Canada ranks on other parameters. So in the first report, where we ranked 13 among 14 countries for cancer drug utilization, we were 7th in terms of our utilization of overall medicines. So cancer drugs were, very much below what our average was for pharmaceuticals across the board. And Canada was ranked 4th in terms of how much we spent on healthcare per capita. So that, to me, is a very strong signal that we are not utilizing cancer drugs optimally in this country. And I wanted to explore some of the reasons why that might be. So I've picked a couple of areas of impact on patients. We could be here all day if I went through all the faults in our patchwork system of coverage and our regulatory systems. But I wanted to focus on a couple of areas today which I think have legs in terms of patient advocacy. And I wanted to qualify that these are my own opinions. These are based on what I hear from patient groups and what I see in the news media. So the first impact is that not all cancer medicines are approved in Canada. I've been keeping track since 2006 of drugs that I see being approved in the US and in Europe. And I've come to a total of over 50 cancer medications and indications that are available outside Canada but are not available in this country. And this newspaper headline here was representing a patient from Ontario who is having to go to the US for treatment and is seeking funding from the province to pay for that. So that's an illustration of the impact on patients. If I could have the next slide. Where we need to look for answers to why this is the case, this is taking a simplified version of Jerry's diagram, looking at the drug development and Health Canada review process. So if I can have the next slide, please. So the questions, why are some cancer medications not available in Canada? There are 3 reasons that I can think of. There may be more, but these are the 3 main ones. The medication may be still in clinical trials, so it hasn't been approved. The manufacturer may not have submitted for approval to Health Canada, or it may be that they've submitted later than in other countries. And the third reason is that the Health Canada review process is slower. So we can go to the next slide. So looking at the regulatory approvals piece of this, again, I've been keeping track of new cancer drugs approved in Canada and comparing those to the first approvals elsewhere in the world, which is usually in the US. And I found that in drugs approved over the last 10 years, that the median delay in approvals is 9 months. So some drugs are approved in a shorter time, some in some cases in a very much longer time. But the median approval is 9 months later. A recent study that came out this May identified 3 months as being the delay due to the Health Canada approval system. And the delay is due to manufacturers' decisions that are unknown. If you can go to the next slide, please. So I think that there is opportunity here for patient groups to take action in terms of looking at the regulatory system and looking at the time that it takes pharmaceutical manufacturers to submit to Health Canada. And one of the areas that came to my attention that where action is happening in this area is with respect to clinical trials. And this, again, a newspaper headline from the Globe and Mail from earlier this year, where Dr. David Stewart and Dr. Bradford from the University of Ottawa are making a plea to simplify the regulatory oversight for clinical trials, to make it easier to do clinical trials in Canada, to make it quicker so that the approval process will be faster, and also, I think, very importantly, so that Canadian patients have greater access to unapproved drugs through the clinical trials process. So that's one impact that I see. You can go to the next slide. The second impact deals with drug coverage. And drug coverage for cancer medications is essential nowadays. I did an analysis of the average costs of cancer drugs approved between 2005 and 2014 in Canada, and tallied up that where I could find the information on the course of treatment that was calculated in. Where those data were not available, I used an annual cost and came up with a figure of over $70,000. Now that is approaching the median net income for Canadian families, so clearly very, very few Canadians can afford to pay for this out of pocket, and they need to have insurance through either the public or the private systems. Sorry, can we just stay with that slide for a second? Another key impact of lack of coverage is that oncologists are reluctant to recommend a treatment for a patient if they know that the patient doesn't have coverage. And this was supported by some academic research done by Scott Berry and his group from Sunnybrook Hospital from the Odette Cancer Center, where he found that a large number of oncologists would avoid discussing these drugs and offering them to patients. And also to a poll that was conducted by the Canadian Breast Cancer Network, saying that the majority of oncologists say that they would never suggest non-publicly funded treatment. So this is rather alarming in terms of patients who do not have coverage that are likely getting a substandard quality of care. So the next slide is just a point to where we would look for answers in terms of coverage. And I'm going to focus in this discussion on the provincial drug plans, on the publicly funded system. Although there are issues with private plans, we won't be going into those today. So what are the biggest holes in our patchwork quilt of coverage? As I mentioned before, there are many. I'm going to cover just 3 issues related to drug coverage. So the first issue, and this will come as no surprise, I think, to anybody on the phone, is unequal coverage of take-home and hospital-administered cancer medications. As Jerry pointed out, if you live in one of the 4 Western provinces, as you can see by the chart that was produced by CanCertainty here, you don't pay a cent for your cancer treatment medications. However, if you live east from Ontario and east in the country, you could be spending anywhere from $1,000 to $23,000. And you'll see the newspaper headline from the Ottawa Citizen from March showing an Ottawa cancer patient who has actually had to sell her business because of her drug costs. So the next slide talks about what action is being taken, and the CanCertainty campaign has been going on for over a year now. It involves more than 30 cancer organizations and other stakeholders, and they have produced a report by the Cameron Institute which outlines the scope of the problem in great detail. And they have also been very successful in taking political action in Ontario and in the Atlantic provinces. So this is one area where if you are not already involved, I would encourage you to join the CanCertainty campaign and to make oral drugs as affordable as intravenous drugs are for cancer patients right across Canada. The second issue that I see is that provinces can be slow to approve new medications. And you'll see some of these headlines that relate to this fact. So for an example, breast cancer drugs have been in the headlines recently. Access to cancer drugs are a worry in Nova Scotia and Prince Edward Islands. Actually, there was just a newspaper report today, the second one that I've seen about Prince Edward Island. Quebec, which if those of us who are old enough to remember the old days when Quebec used to approve drugs very readily. This is the second newspaper headline that has come out within the past year and a half, dealing with Quebec being a laggard in terms of approving new cancer drugs. So the next slide is something that this is data that I have worked up on my own. It looks at drugs that have been approved since 2006, cancer drugs and indications. And these data are accurate as of August 2015. So when I looked at which drugs had been funded, rejected, and were under review or under negotiation with the Pan-Canadian Pharmaceutical Alliance, these are the numbers that I came out with. And in terms of the speed of approvals, I wanted to draw your attention to the bottom row. So you'll see that in terms of the number of drugs that are currently under review or under negotiation, the Western provinces are doing pretty well as a proportion of the total drugs under consideration. Ontario is also doing very well. Ontario, in fact, has approved enormously in this area over the last 5 to 10 years. However, when you look at Quebec and points east of there, you can see that the delays start to become very significant. And these review processes are keeping access away from cancer patients. Also wanted to draw your attention to Yukon Territory and NIHB, which stands for Non-Insured Health Benefits. And this is a program that is used to cover First Nations and Inuit populations across Canada, as well as the formularies adopted by Northwest Territories and Nunavut. And you can see that while Yukon is quite speedy in terms of making formulary decisions, NIHB is not. There are a considerable number of drugs, and these are just the oral drugs that I've taken here. A considerable number of drugs are not on the formulary, but are in other provinces. So this is another area of focus for advocacy. So on the next slide, you'll see my recommendation, and that is that I think there is a place for advocating for standards, national standards for provincial decision timelines. I think the implementation of PCODER over the last several years has been a great success story for Canada. I think it's meant that we have a uniform way of evaluating drugs. They are relatively speedy in terms of getting their decisions out within usually a 6-month period, and most provinces will eventually follow those recommendations. So I think the next logical step that I can see is to hold provinces to account for making timely decisions based on those PCODER recommendations and on the price negotiations that may follow. So turning to the next slide, this is the third issue that I wanted to raise, and the last one. to do with coverage, and this is around the authorization criteria, which can in some provinces be overly strict in my opinion. And this used to be a huge issue in Ontario, and you'll see the headline there from 2011. This is regarding a patient called Jill Anzaret, and the headline is Ontario Woman's Tumor Caught Too Early to be Treated. What happened was Jill had been diagnosed with having a very small breast cancer, and unfortunately it was too small to fit within the guidelines for treatment with Herceptin. The government policy said that the tumor had to be 1 centimeter or greater in diameter, and Jill's had been caught early, so it was only 0.5 centimeter. So while it made no sense to deny the treatment, that was the way the authorization criteria were written, and she was denied treatment. Now that case achieved so much publicity that, to its credit, Ontario did turn around and create a couple of new funding programs to deal with unusual clinical situations such as this. And I'm not as familiar with how other provinces handle these kind of situations, but as you'll see from the other headline there, the Kimberley man denied funding for life-saving drug. This is happening in BC, which used to be at the forefront of approving drugs even before they had Health Canada approval. So I think that this may be an issue across Canada, and it's something that I think needs further attention and potentially advocacy. So turning to my last slide, my recommendation is to advocate for having an independent appeals process within each province so that patients have recourse with their oncologists to make the case for why a particular drug is recommended. I know in some provinces this happens informally, but I think it really needs to be a formalized process everywhere. So with that, I will thank you very much for your attention and turn it back over to Jerry to field the Q&A session.
Thank you very much, Susan. That was excellent. An excellent overview of the things that are impacting patients in terms of the disparities that exist in Canada. I think that you know, as you, our listeners have heard from both sort of my review of the system and your overview of some of the issues at hand as a result of those, there are some certainly some things to talk about. So I have received a question from one of the participants on the call, and that's great. I would encourage other people to jot your questions down in the question box in the control panel for the webinar. Be happy. We have about 15 minutes to address questions, so please feel free. Don't be shy. Your questions are welcome. So the question that I did receive, and I'll ask you, Susan, to sort of have a crack at it, and then I'll perhaps make some additions. But the question is, if medication is not approved for funding in Alberta, how do we appeal to have it approved? And similar to U.S. Medicare, where an appeal is approved or denied within 24 hours, is something like that available in Alberta, or maybe in other places as well, since we're going to be talking about it? Any comments on appeal processes?
It's a great question, and I have two answers. The first one is I don't know how the system works exactly in Alberta, but I think the first step might be to see where the drug is in the approval process. So if it has already been approved by Health Canada, it may be under review by the Pan-Canadian Oncology Drug Review. And on their website, you can find out which drugs have been submitted for review and what the status is. It may also be under negotiation with the Pan-Canadian Pharmaceutical Alliance. And again, on their website, you can find out retrospectively if a drug has been approved or a recommendation made, or if it's pending review. So you can you should be able to find out what the status of it is. If those boxes have been checked and it's in the hands of the Alberta Cancer Agency or the Alberta Health Services to determine whether or not they're going to fund it, that information may be available through a government website or through a cancer treatment center. And if the decision has been made and it has been negative, they may have an appeals process for exceptional access, and you'd have to speak with your oncologist and find out what that appeals process might be.
Thanks, Sue. So I'll just make a couple of comments as well, if you don't mind. So in terms of medications that are not being sought for approval in Canada, so the manufacturer has either determined that they're not going to come to Canada or they haven't yet come to Canada, there is a process within the Health Canada framework called the Special Access Program, and that is to allow access in life-threatening situations to medications that are otherwise not available in Canada. So that's one way of gaining access to something that hasn't been put through the Canadian process. There is no formal appeal process beyond that within the Health Canada framework or within the HTA process. There's a PCODER has what's called a procedural review available, which allows the participants in a review to question whether or not PCODER actually followed its own process properly in the case of a particular medication. But in general, if you get a negative reaction response recommendation from PCODER, the approach is for you to develop or gain access to new data and resubmit to PCODER in the hopes that the new information will make an impact. All of the provincial drug plans have restrictions within their policies that say that if a drug is under review by CADF or through the province themselves, then it's not covered until that process is complete, and there's no appeal mechanism for that. But as Sue suggested, there are in some cases, well, in most provinces, they have an exceptions process that allows for an individual clinical review to be done if a medication is not available on the formulary. So, you know, depending on, as she said, where it is in the process, you know, there are different ways of moving forward. Hopefully that answers your question sufficiently to move you forward. Let me get to the next question here. There's a question that says, how do you feel about the tear-jerking media campaigns to get very expensive treatments which may only extend life by a month or two? Susan, I don't know if you want to comment on that question.
Yeah, I take it from the writers, the way the writers pose the question, that there's an implied criticism. And I understand that perspective. I think in the early days, especially with Herceptin comes to mind as one of the sort of landmark campaigns in Ontario, and I can speak to the Ontario experience because I was aware of it happening at the time, where patients were coming onto the lawn of Queen's Park to the legislature, holding placards, really pressuring politicians into approving Herceptin, putting it on the formulary. And at the time, it was on the formulary in many places across Canada and around the world, but not in Ontario. So I think that was an act of desperation. I think that cancer patients had taken a page out of the book of AIDS activists and seen what political pressure could achieve in terms of moving the agenda forward. I think that has largely changed. I think that governments have, in some areas, and again, I'm largely speaking to Ontario, governments have become far more aware of the issues and have started to listen and to even, you know, be proactive in some areas. And I think that that is a far more effective process if you can, through the political process, get to sit down with both bureaucrats and politicians and work together to try and find a way to make it happen. And I think also that the PCODER process has brought a lot of rationality into this forum, so that there is now a place for patients to have input into how that review is done. I think that's very welcome. It's been long needed. I'm so pleased to see that they accepted that advice and are taking patients' input into the review process. So what do I think of them? I think that they are at times needed, but I would see them as a last resort.
Thanks, Susan. So I'm going to move along because we're getting a couple more questions, and the next question is from somebody who lives in BC. And the question is, currently a drug for treatment of CLL, irutinib, is not approved for frontline use here, but it is in other provinces. What can I do? Appeal, go to other provinces. So again, once again, Sue, I'll let you sort of take a crack at it, and maybe I'll comment afterwards.
Okay. I believe there is a case-by-case review process in BC, so that would be my first step. I think it's a fairly extraordinary thing to go to another province simply to get a particular cancer drug, although some patients have done that. There is a waiting period before you can be eligible for provincial coverage in another province, so I would bear that in mind. But I think going through some kind of an appeals process or a case-by-case review is your best shot.
Yeah, and I would agree, Susan, with those comments. Just so you know, these case-by-case reviews are really dependent on the support of your oncologist. So as a patient, there's no sort of process available for you to sort of make that appeal for an individual case review. However, if the oncologist is prepared to assist you and make the case, then yes, as Sue said, and not only in BC, but in all the provinces across Canada, there are special authorization programs or individual clinical reviews, or some other terminology that essentially means the same thing, which is the physician makes a request or an application to the province for special consideration under the circumstances that are relevant to that particular patient, and the decision is made whether or not to provide special funding in that context. And so that is available everywhere in Canada. Certainly that's the first, that's your first, sort of line of attack that I can think through. Beyond that, as Sue suggested, it's certainly available to you to sort of go to another province, but as she indicated, there's usually a 3-month minimum wait before you're eligible for the provincial Medicare or pharmacare program in any case. So just something to be considered. I got another question here about the purpose of the PCPA, and so this question supposes that the purpose of PCPA is to make medications affordable for public drug plans, and I guess there's certainly part of that in its mandate. The question, though, is, but at what point does the PCPA process become a disincentive for manufacturers to bring innovative medications into Canada? So maybe I'll take a quick stab at that one, and then I'll ask Susan if she wants to comment as well. So, the rationale for the PCPA has been essentially to do a couple of things. One is to help overcome these disparities that we've been talking about at some level. Not a panacea by any means, but one of the intentions is to make sure that all of the provinces are making decisions about reimbursement of treatments based on a similar set of data and evidence that support the medication. So by having a collective health technology assessment review process through PCODER and CDR, and then a collective discussion about the value of that medication and a collective negotiation around what is an appropriate or affordable price. That's all intended to ensure that at least the provinces are starting from the same base of information in order to make that determination. Now, obviously, each of them is going to have their own capacity to fund these things, their own systems, as I described a little earlier. So there are going to be some distinctions, but the purpose is really to try and create more consistency at the same time as finding the proper value from the province's perspective in terms of what they're prepared to pay for a given treatment. So yeah, and there is an attempt to make these things more affordable and to expand the capacity of the public payer to provide a greater range of new innovative medicines. So there's good rationale for it, but clearly it has added time and complexity to the system in Canada, which was already in the context of international comparisons already a lengthy and complex process. So no question that there is a trade-off here, but I think the argument you get from the provinces is that without the PCPA, you get a lot more no's than you're getting in the current context, and as a result, it is in fact making an important difference for patients by giving them the capacity to fund more innovative medications. But there's no question that it creates serious challenges for manufacturers who want to bring their medications into this marketplace. And I would hesitate to say that it would provide a big enough barrier so that a company wouldn't consider coming to the Canadian market. But it's certainly a consideration, and one that is certainly taken into consideration. So I don't know if you want to add anything to what I've said here.
I agree with everything you've said, Jerry. I would just add, it's impossible for us to say at what point it's going to become a disincentive, because all of these negotiations are opaque. They're all in confidence, as is the case for many jurisdictions around the world, including in the U.S. So it's really impossible for us to say, are we getting a fair price compared with European countries or Medicare in the U.S. as examples. I would say, though, that I think PCPA, personally, I think it's a good thing. I think it gives some consistency across the country, and it gives Canadians an assurance that we're not overpaying for cancer medications. And I think that there may be opportunities for Canada to take a lead role in terms of helping to reduce the cost of developing drugs in the first place, which is largely what is driving those high prices. And I think, again, if there is opportunity for the industry to work with regulatory authorities and to work on an international scale, I think that that there may be opportunities there to bring the cost of development down and bring the cost of drugs down, so that while we're taking away at one end of the spectrum in terms of the price they can charge, we're giving back in terms of making the processes simpler.
Thank you for those for your responses, Susan, and for the questions that we've received. We've got another maybe 2 or 3 minutes, and so maybe I'll just put out to Sue the one last issue that we can maybe make a quick comment on, and then we'll close this up for the day. But let's have a comment or two, Sue, if you don't mind, on the prospect of a national pharmacare program and its impact on cancer, its potential impact on cancer patients, depending on how it's defined, obviously. Yeah, just maybe give me your comments on where national pharmacare is at in your mind, and then we'll close up.
Yeah, it's a great question. It's something I've struggled with, because on the one hand, there are many Canadians that are either uninsured or underinsured, and I think that having a national pharmacare program would make sure that everybody in Canada was eligible for coverage, and that there was consistency across the country in terms of which drugs were on the national formulary. I think a few issues that spring to my mind in terms of the situation of cancer patients that I think need to be part of the conversation, especially now that we have a new government federally that has said that it's in favor of a national program. I think making sure that the national formulary covers both oral or both take-home and hospital-administered cancer drugs. Making sure that the fact that patients have to pay co-payments for many in many publicly funded programs across the country. I think making sure that cancer patients do not have to pay out-of-pocket expenses. I think that would be very important. And I think those are the two things that I would want to make sure were on the agenda, representing cancer patients' interests.
Thanks. And maybe I'll just make a closing comment on that, and then we'll thank everybody and move on for today. But just in terms of national pharmacare, we just need to be a little bit careful about what we wish for in the context of this. I mean, yeah, as Susan said, certainly a national program would ensure that we all have access to the same medications across the country. But I think one of the things we need to combat or be wary of is what's that list look like? I mean, is it the list that's available in PEI, or is it the list that's available in BC? And or is it the list that's available in the context of a privately sponsored program where there tend to be fewer restrictions on coverage? So as we're developing a national program, we need to be conscious of ensuring that the newest innovative medications are going to be available, and that the system isn't going to be designed such that manufacturers are not going to want to come here to bring their drugs to the population. So just a couple of things to consider as we get into this broader debate over the next little while. So with that, I want to thank Susan for her important contributions to I think a very informative and good dialogue today. So that was excellent, Susan. I really appreciate your contributions, and also a big thank you, as usual, to Matt and the crew at CCSN who have helped with all the logistics, and of course to all of our participants. I hope that we provided you with some important information to help you as you move forward in your advocacy efforts, regardless of whom you're representing. So thank you so much, and we'll look forward to the next webinar session through CCSN. Pass it back to Mona.
It's Matt here. Mona's got a prior commitment, so I'm going to just say once again, echo your comments, Jerry. Thanks to both of you, Jerry and Sue, for coming on today and offering your expertise to us. We'd also, again, just like to thank our sponsors for our 2015 webinar series, Novartis, Merck, and especially Boehringer Ingelheim for making today's webinar possible. If anyone is wondering who's still on the line, this webinar will be available online tomorrow. There'll be a full VOD on YouTube, as well as links to the slides on SlideShare, and we'll send an email out tomorrow afternoon with links to both of those, so you can all review the webinar and the content tomorrow. So we'd like to thank all of you for attending online from coast to coast to coast today, and we'll see you all next time.